Greetings, everyone. This is Andrew Boland, your Assistant Medical Director, here to provide a few QA updates as part of the Medical Director's Update. So the purpose of this talk is to kind of give some general feedback about some items that we've seen doing QA the past few months. And I want to go kind of lightning fast through a few quick general items and then dive into a little more detail about a few items and then talk in detail about refusals and refusal documentation. So just a quick reminder for everybody. I know it can take some getting used to getting QA messages, but I know I've mentioned this a lot, but doesn't mean you're in trouble. It's literally just a way to get feedback, a way to learn, a way to make the system better. The vast majority of the feedback that we're giving is just things that needed clarification in the documentation. So getting a QA message or a QA flag is not like getting called to the principal's office. It's simply just some feedback and hopefully something that just needs some clarification and definitely doesn't mean you're in trouble. So let's jump into some general items to cover. So first off, early resuscitation. I know this is something that I've talked quite a bit about over the past few months, but it's really important to make sure we're bringing our bags and our monitors to the patient's side for initial contact, because we never know when we're going to encounter someone who's hypoxic, who's in an unstable tachyarrhythmia or bradyarrhythmia, or is hypotensive. And for these patients, we really want to emphasize early resuscitation and doing resuscitation on scene upon initial contact before moving to the ambulance. Now, I'm saying this in terms of critical medical patients, right? For those critical trauma patients, we want to minimize scene time and get them to the hospital, to the trauma center as soon as possible. This is just medical patients that I'm talking about. And certainly, we don't want to prolong hypoxia or hypotension, or even worse, we don't want to have the patient decompensate to the point of coding when we haven't done anything to help prevent them from code in the first place. And that's certainly a terrible feeling. So certainly early resuscitation for our critical medical patients is key. Another just real quick general item, vital signs. As you all know, there are times that erroneous vital signs sneak their way into the chart. Certainly we're limited by our technology and our monitors and our SpO2. And there are going to be times when a funky heart rate or SpO2 or blood pressure make their way into the chart. And really just making sure that you clarify those erroneous readings in the narrative is super useful for charting. And that way it just doesn't look like we failed to address someone's hypotension or hypoxia or tachyarrhythmia, and just helps clarify that item. Another quick general item that kind of put in a separate slide because I thought it needed a little more attention was document only what you do. And this is particularly true with regard to the physical exam and some of the EMRs, is that some of the physical exams will kind of pre-populate parts of the physical exam. The one that comes to mind is it'll pre-populate all 10 toes as normal, and it'll literally put a line, right first toe normal, right second toe normal, right third toe normal, so on and so forth. And if you actually look at all 10 toes, then excellent, that's perfectly fine, perfectly legitimate to document. But if you didn't, it's really kind of fraudulent to document something that you didn't actually look at. And where we can get in trouble with this is, take for instance, the diabetic patient who actually has only 8 toes because they've had a couple amputated, yet we documented 10 normal toes. You can imagine that if that case ever went to court and you were called up on the witness stand and here you documented 10 normal toes and the patient only had 8 toes to begin with, you could see how an attorney could really tear that report apart, and then you would be stuck with no leg to stand on. So make sure that you only document what you actually do to make sure you're protected from that. And finally, for the quick items, escalating care. And I include this separately in a separate slide as well, because I thought it was important to mention and definitely something to think about. So what I mean here is that when the patient's hypoxic, let's say continues to be hypoxic after nasal cannula, you'll certainly escalate the non-rebreather or even CPAP if appropriate and not contraindicated. It's certainly called for when you have continued hypoxia. Same goes for severe hypotension. Let's say that you have a long transport time and you have someone who remains severely hypotensive after IV fluid bolus. We always have epi drips in our back pocket, and that's always an option to consider. It's not only for those post-arrest patients. Whenever you have questions about this, you can certainly reach out to medical control. We'd be happy to help navigate that decision-making as well. So let's jump into a few more specific items and in a little more detail. First off, let's talk about EKGs. So really, it's important to make sure we're getting EKGs for all of our chest pain patients. That goes without saying. We also get EKGs on those patients with anginal equivalents. So what do I mean by anginal equivalents? Well, things other than chest pain that can be signs of cardiac ischemia. Jaw pain, shoulder pain, arm pain, back pain, epigastric pain. All of these can be signs of cardiac ischemia and warrant an EKG. And remember, shortness of breath, even in the absence of chest pain, can still be an anginal equivalent, and there's an indication for EKGs. And the timing of EKGs is something that's really important, because our job, or one of our main jobs in performing EKG, is to identify STEMIs so that we can activate the cath lab. And as all of you know, activating the cath lab and actually getting the ball rolling on getting the cath lab ready is something that takes a decent amount of time. Obviously, the cath lab itself has to be prepared, but oftentimes the cath lab team and the interventional cardiologists have to be called in for home. So it's something that takes a good amount of time to get all the pieces in place in order to get someone their stent or PCI. The key here is to make sure that for those patients with chest pain or anginal equivalents, we're bringing the monitor to the patient's side upon initial contact and getting that EKG as soon as possible before moving them to the ambulance when possible. The key here is that we can identify the STEMI early and then contact the cath lab, or rather contact the hospital and notify them of the code STEMI as soon as we have identified a STEMI on the EKG. This could be even before we're moving the patient to the ambulance, or maybe even as we're moving the patient to the ambulance. That way, we can go ahead and get the cath lab activated and get the ball as soon as possible. One more quick aside about EKGs. Posterior and right-sided EKGs are super useful when you have concern about a posterior or right-sided STEMI, but the initial traditional 12-lead placement does not show anything meeting STEMI criteria. However, when you have an initial EKG such as this one here, which demonstrates a clear inferior big STEMI, someone that needs the cath lab right away, this isn't someone who you need to take the time to do a right-sided or posterior EKG on. You already have your answer. You know that this person needs a cath lab as soon as possible. And spending time in order to get another EKG instead of expediting their transport to a cath lab, it's just wasting your time. You know the answer. The patient has a big STEMI. They need the cath lab. You're done. Go ahead and call it a code STEMI and move on. All right, so the next topic that I want to talk about is hyperkalemia and dialysis and renal failure patients. The first thing that I want to cover here is when you look at the protocol, well, the very first thing there is cardiac arrest. So all patients who are on dialysis or have renal failure, if they are in cardiac arrest, the first thing it says, give calcium and sodium bicarb. So this could be a patient at the dialysis center. This could be a patient at home who has a history of end-stage renal disease. So always important to ask that history. That's one of the first things I try to ask family or friends who are on scene. But make sure to look at your patient. Look for signs that they have ESRD. Do they have a peritoneal dialysis catheter in their abdomen? Do they have an obvious fistula in their arm? If they do, go ahead and treat them as if they have renal failure and are on dialysis and give the calcium and sodium bicarb. For somebody in cardiac arrest, it's unlikely to cause any harm. And every now and then you'll get a clean cardiac arrest save from someone who is actually hyperkalemic, got calcium and bicarb, and you saved their life. As you look further down the renal failure and dialysis protocol, you'll notice that all of these patients should get a 12-lead EKG. And it's important to remember that we're not just getting EKGs to look for STEMIs, right? We're getting EKGs to look for arrhythmias as well. And remember, any of these renal disease patients who have signs of hyperkalemia on the EKG should get calcium and bicarb. So just a quick reminder of what are those EKG changes. Well, first off, obviously those peak T waves, that's a classic finding. Here, this EKG has some really nice example of peak T waves. The wide end QRS is another classic finding. I mean, this EKG just looks nasty. This person clearly needs calcium and bicarb. But hyperkalemia is kind of funky. It can cause a lot of weird EKG changes. It can cause bradyarrhythmias, tachyarrhythmias, junctional rhythms, AV blocks. So whenever you have an ESRD patient or end-stage renal disease patient or someone who is on dialysis with weird EKG changes, always consider that this could be hyperkalemia and consider giving these patients calcium and bicarb. When in doubt, you can always contact medical control and transmit the EKG, and we'd be more than happy to help you navigate that decision making. Just a quick aside here, remember, peak T waves isn't necessarily referring to how tall the T waves are. It's referring to how pointed the T waves are. I like to think of a peak T wave as a T wave you wouldn't sit on. If the T wave's pointy, it's a peak T wave, that's a sign of hyperkalemia. Go ahead and treat with your calcium and bicarb. All right, so next topic to talk about is IOs. So it goes without saying, if you have a critical patient with hypotension, an unstable arrhythmia, et cetera, and you fail on your IV access, IO is certainly indicated. I like this picture because it shows a doctor doing an IO on himself to show that it's not too painful. And I think that we tend to shy away from IOs on the patients who are alert-oriented GCS 15. But when you think about it, a lot of times when you're making multiple IV attempts on these patients, that it might be even more humane to go ahead and do the single IO instead of making them a human pincushion and continuing to try to place IVs. A lot of times it might be better or more comfortable for the patient just to get that one IO attempt, get the access instead of getting multiple IV sticks. It's just something to keep in mind. Next topic to talk about, airway confirmation. So just a reminder, no end-tidal CO2 equals no airway. So just a quick reminder, whenever you are getting that solid line with a reading of 0 for your end-tidal CO2, that means that you're not ventilating the patient. Whatever airway that you're using right now, it's not working. You need to do something different. That might mean that we adjust the king. That might mean that we take out the king and we intubate the patient. That might be that we remove the ET tube and revert to a king. So if you're getting that solid line of 0, the airway isn't working, you don't have an airway, you're not ventilating the patient, something different needs to be done. Now, it's important to differentiate this from that dotted line of zero. The dotted line of zero means that there is something mechanically wrong with the device, most often that the tubing is clogged. And I know a lot of you have different methods for unclogging the tubing. That's great. Or you can try replacing the tubing. But one thing I want you to keep in mind is that there have certainly been instances where we get so focused on trying to troubleshoot the tubing that we end up having a prolonged time that we have an airway in place, but we don't have a confirmation that it's actually doing anything. So let's say you have a king in place or a ET tube in place and you're getting that dotted line zero and you've been fooling around with it and someone's going to get more tubing, a clean thing of tubing, and before you know it, 10 minutes has passed and you have no idea in that period if you've actually been ventilating the patient or if that airway is in the right place. And I would just caution you to, if you are coming across that dotted line for a prolonged period, it's probably better to just revert to a BVM and abandon the airway if you're not going to have any way to confirm it. Now, certainly it's ideal to have an airway, that goes without saying, but worst case scenario, if you have prolonged that dotted line zero, you don't have a way to confirm the airway, or you're getting that solid line zero and you've tried the BVM, or sorry, you've tried the king, you've tried the ET tube and you're still getting that solid line zero, there's no shame in reverting to BVM. So no end tidal equals no airway. So speaking of ventilation, let's talk briefly about ventilation during cardiac arrest. And the point I want to cover here is to avoid hyperventilating these patients. So the goal should be 1 breath every 6 seconds, which is equivalent to 10 breaths per minute, which is equivalent to 1 breath every 10 to 12 compressions if you're doing 100 to 120 compressions per minute. And the reason that you don't want to hyperventilate these patients is because the more that you hyperventilate them, the more you increase their thoracic pressure. So what happens when you increase intrathoracic pressure? Well, you end up compressing the vena cava that to supply blood back to the heart. So certainly that's the last thing you would want to do when you have someone in cardiac arrest in a low flow state to begin with, is prevent even more blood from coming back to their heart. So certainly avoiding hyperventilation is key. And the last thing you want to have happen is the Lazarus effect. And this is just a point that I make because I think it can really highlight the harms of hyperventilation. So I don't know if any of you are familiar with the Lazarus effect. They made a movie that was some horror movie about it, but it's when you come back to life after being pronounced dead. And this is something that has actually happened to me. It's the worst feeling in the world to be called back to a patient's room who you just pronounced dead because they're breathing and have a pulse, or to be called back to a scene because that patient you just pronounced is now breathing and has a pulse. And one of the reasons hypothesized as a cause for the Lazarus effect is hyperventilation. So you can picture a scenario where you're working at cardiac arrest, the patient's being ventilated too aggressively, and there's no return of spontaneous circulation, and you end up calling the code. Well, what happens when you call the code and you pronounce the person? Well, you stop doing chest compressions and you stop ventilating the patient, and their intrathoracic pressure will gradually decrease. Well, when it gradually decreases, there's a possibility that compression of the IVC and SVC will be decreasing and get more blood flow to the heart. And a pulse could come back. And that's obviously a super traumatic thing to have happened to the crew, to the family. And it's actually has happened. I mean, this is an article back from August 2020. Woman found alive at Detroit funeral home after she was declared dead. So certainly Nothing you would ever want to have happen to you. And just one other reason why avoiding hyperventilation in cardiac arrest patients is key. So a quick reminder of needle decompression and the indications for needle decompression. Patient must be hypotensive with clinical signs of shock and at least one of the following signs: JVD, tracheal deviation, absent or decreased breath sounds, hyperresonance to percussion, or increased resistance when ventilating a patient. So yes, a patient can be decompressed even in the absence of decreased breath sounds. They just need hypotension, clinical signs of shock, and at least one of the following signs. A reminder as well, patients who are in trauma arrest and meet the requirements for resuscitation, so patients that we're not pronouncing immediately, should be decompressed if they have chest or abdominal trauma. And this includes abdominal trauma because we often don't know the trajectory of bullets or bullet fragments. So if you're in trauma arrest, probably best to just go ahead and decompress. If no ROSC after you decompress the suspected side, you can go ahead and decompress the contralateral side. Really quick reminder about naloxone. Naloxone is given to be titrated to adequate ventilation and oxygenation, not to restore consciousness unless you want a combative, angry, refusing, vomiting patient in the back of your ambulance. There are lots of ways to do this. You can give 0.4 milligrams at a time. You can dilute that 0.4 milligrams by a factor of 10 in a 10 cc syringe. You give 0.04 milligrams at a time. I think the key thing though is that if you have that NPA in, you got a good sealer, you're bagging well, you don't have a lot of resistance, you are getting good SpO2s, that you really have a lot of time to titrate to ventilation and oxygenation and restoration of that, not the patient waking up and being angry. So titrate to ventilation, oxygenation, not level of consciousness. All right, let's take a little bit of time to talk about refusals. And I kind of broke this into a couple parts. First, I want to give some kind of pearls of knowledge about refusals, and then talk more specifically about the necessary elements in the narrative and the documentation for refusals, and then that will conclude the session. So first pearl is that refusals are kind of a weird thing. We're protected by what we write in the narrative, not necessarily what is auto-populated in the statement that the patient signs. It's a weird thing, and it's the same thing in the ER. In the ER, we're not protected by that AMA form that the patient signs. What we're actually protected by is what we write in the patient's chart, and the same goes for EMS. So that's why I wanted to spend time talking about this. Pearl number 2, just because the patient was unconscious at one point does not mean that they no longer have capacity even when they regain consciousness. So just because someone was unconscious doesn't mean that they never have capacity ever. You can imagine situations where someone was hypoglycemic and they get D10 and are now normal glycemic and alert and oriented and have capacity. You can imagine all of the overdose patients who end up refusal, etc. But just because you're unconscious once, for whatever the reason, does not mean that you no longer have capacity, period. Power of attorney does not take effect until the patient is incapacitated. So just because you have a power of attorney listed does not mean that that person always makes your decision. For instance, I could list a power of attorney for myself just in case I were to have a bad accident, have a cardiac arrest, end up on a ventilator, someone needs to make medical decisions for me. And that does not mean that right now, if I were to call 911, that I wouldn't be able to make my own decisions. Power of attorney only goes into effect when the patient is incapacitated. And that goes for everyone, regardless of your age. If you're 95 and you have medical decision-making capacity, then that doesn't mean that your power of attorney gets to make you go to the hospital or gets to say, no, you're not allowed to go to the hospital. If you have capacity, you can still make your own decisions. I think it's important also to note that there's a difference between capacity and competency. So us as medical providers, we are determining, does a patient have capacity to make a medical decision or refuse care? Competency is a totally different term. That's something that's determined by a judge and a court. Okay, so totally different than capacity, which is what we're determining in the field, that the person has capacity to make their decisions. Next pearl, once you are an adult, you sign your own refusal. So if you're 18 and mom does or doesn't want you to go to the hospital, they don't make that decision for you and they do not sign a refusal. Once you are an adult, you sign your own refusal. On this topic, yes, there are instances where minors can be emancipated. What that means is that that those individuals are less than 18, but they legally make their own decisions. They do not have a legal guardian. And there are certain legal steps and criteria to become an emancipated minor, but all of these emancipated minors should know the deal. They should have their paperwork handy to give to you that states that they're an emancipated minor. And if you don't have the paperwork, you're not an emancipated minor. And if there's ever any question about that, just go ahead and call medical control and we'll help you navigate through that. But generally speaking, these people, they know the deal. They know that they need their paperwork and they should supply that to you. Don't overdiagnose in the field or recommend alternatives. Certainly, we are incredibly limited in our diagnostic capabilities in the field. So saying things like, all you do is sit in the waiting room or go into ambulance won't get you there any faster, or why don't you go urgent care? It's actually against protocol. It states explicitly in the protocol that we're not to recommend anything other than transport. I would also encourage you to be wary of making those specific diagnoses in the field, such as anxiety. Anxiety is one that I really ask people to shy away from because it's really not even a diagnosis that we're making in the ER. It's a diagnosis of exclusion. So we don't know the patient isn't anemic. We don't know the patient doesn't have hyperthyroidism. So try and shy away from, especially these patients who are refusing, putting in a very specific diagnosis that's actually a diagnosis of exclusion as the impression. This next one I put in bold because this is very important. So be wary of hypotension, hypoxia, or hypoglycemia. So certainly someone who's bradycardic, tachycardic, hypertensive, hyperglycemic, their respiratory rates a little bit off, aren't prohibited from having capacity by those vital signs alone. However, we need to be very, very careful about people with any of these three abnormal vital signs, hypotension, hypoxia, or hypoglycemia, and thinking critically about whether these individuals actually have decision-making capacity, as these individuals may not have oxygenated and glucose-filled blood making it to their brains. So I'd encourage you to please call medical control for all of these patients if you have a hypotensive, hypoxic, or hypoglycemic patient trying to refuse care, as this really needs to be considered on a case-to-case basis as to whether the patient has capacity or not. Next, it is okay to tell the patient they should go to the hospital. Yes, we offer transport to everyone, but it's okay to tell that patient with chest pain, hey, you should really go to the hospital. You don't look good. I'm worried about you. Totally okay to tell the patient, I think you should go to the hospital. The patients are looking at us as the medical professionals to help them make that decision. And it's okay to tell them, I think you should go to the hospital, ma'am or sir. Lastly, for our refusals, pearls, you can always call medical control. It's always better to call us than not. calling medical control automatically takes a lot of the responsibility off of you, puts it on the physician. A quick side note, to remember to call medical control for all those refusing suicidal or homicidal or potentially suicidal or homicidal patients. Remember, when in question, the burden of proof is on the patient who was purported to be suicidal or homicidal to prove that they're not suicidal or homicidal. This comes up most often when, say, a third-party caller calls 911 claiming that the patient's suicidal, for instance, send a suicidal text message. And in these cases, really, it's another instance where medical control should be called to help make that decision and navigate that. So let's talk about what elements we need to document in the narrative. So let's jump into it. So first, the patient's alert and oriented and is GCS 15. So GCS alone isn't sufficient. GCS just tells us whether you're in a coma or not. You need to include that the patient is alert and oriented as well. Next, the patient has normal speech and gait and does not appear clinically intoxicated and has decision-making capacity. So we've all come across the patient who's had a couple beers and wants to refuse. And that's okay if you're not clinically intoxicated and still have medical decision-making capacity. So what exactly does clinically intoxicated mean? Well, that's a bit of a gray area, but generally, if they're not slurring their speech, they have normal gait, and they have linear thought processes, they are not clinically intoxicated. It's important to note that we control what's put in the chart here. A good phrase might be the patient admits to ETOH tonight, but the patient has normal gait and speech and thought processes and does not appear clinically intoxicated. That's a lot better than putting, quote, the patient admits to drinking to excess tonight or something along those lines. So let's just make sure that if the patient truly is not clinically intoxicated and has decision-making capacity, that we're not undermining our own assessment of the patient. Next, the patient understands all risks, including permanent disability or death, and is able to repeat back all risks. The italics and bold portions are key here, and it can be useful to include specifics. For instance, that the patient was made aware that the effects of Narcan, that the effects of opiates can outlast the effects of Narcan, or that their insulin or sulfonylurea may outlast the effects of the D10 you just administered them, and they could become hypoglycemic again. So definitely something that's important to note. Next, the patient was made aware of all abnormal findings and our limited ability to interpret them in the field. And that includes all abnormal findings, that high heart rates, the low heart rate, the low BP, the high BP, the high blood glucose, that right bundle branch block, that first degree AV block, because when the patient's making decisions about their medical care, it's really imperative that they make the most informed decision possible. You could imagine a situation where something goes wrong with the patient and they say, well, I wasn't made aware that my heart rate was 150 and that was abnormal. Or I wasn't made aware that my blood pressure was 200/100 and that's abnormal. So if I'd known that, I would have gone to the hospital, et cetera, et cetera. So making sure that we state that explicitly is really important. Next, attempts were made to convince the patient to accept transport and ensure they have a safe disposition. So just document whatever conversation you had with the patient. Sometimes talking to family or friends with their permission can help convince the patient and ensure the patient has a safe disposition if possible. So what do I mean? For instance, the hypoglycemic patient has follow-up with their doctor, will check their sugar every hour, will not be left alone, et cetera. Also, as an example, the overdose patient won't be left alone and the family knows to check on him or her and call 911 immediately for any changes. Another quick side note here, remember, you can still treat patients even if they are going to refuse transport. And I'm not just talking about hypoglycemic patients or overdoses, but I'm talking about the asthma attack patient can still get meds and steroids before refusing transport. The patient with an allergic reaction can still be given full treatment, steroids, Benadryl, epi, if indicated, before refusing transport. Just because they're refusing transport does not mean that we withhold treatment. Certainly, you can refuse treatment, but refusing treatment and transport are totally different things. Next, the patient was made aware to call 911 if they have any change in condition or they have a change in heart, and we would be happy to see them again. It's certainly important to mention this. And finally, when applicable, the patient denies suicidal ideation or homicidal ideation. That goes without saying. Patients who are suicidal or homicidal cannot refuse care. Sure, this doesn't probably need to be included for every single patient, but it probably should be included at least for the overdose patients to confirm that that overdose was accidental, not an intentional overdose or an attempt at self-harm or suicide. So let's just go through, as a summary, a nicely written example narrative from a refusal. So Medic X was dispatched for a 30-year-old male overdose. Upon arrival, patient was found apneic and GCS3 with heart rate of 70, BP 120/90, SpO2 60%, restore rate 0. NPA was placed and the patient was bagged via BVM with improvement of SpO2 to 100%. IV access was gained with 18 gauge and the ready AC, and the patient was administered a total of 1 milligram naloxone, after which patient regained consciousness. Glucose was 140. Subsequent vital signs were BP 142/92, heart rate 110, SpO2 98%, on room air, respiration 16. Now, we had some abnormal things there. We had hypertension, tachycardia, and hyperglycemia. After regaining consciousness, the patient refused further care. Patient was GCS 15, alert and oriented with normal speech and gait, and has decision-making capacity. He was made aware of all risks, including death and permanent disability, including the risk that the opiate in his system could last longer than the naloxone that was given to him and cause him to die. He is aware that he almost died. He endorses understanding and is able to repeat back all risks in an appropriate manner. He stated that this was an accidental, unintentional overdose after switching dealers and denies SI or HI. He denies any other drugs or ETOH. Family at patient's side tried to convince patient as well, but patient continued to refuse. Patient was made aware of all abnormal findings, including his hypertension, tachycardia, and hyperglycemia, and that we are limited in our interpretation of these findings in the field. We did convince the patient to spend the night with his family, and family planned to check on him every 30 minutes throughout the night and to call 911 back for any changes. Patient was also made aware that he can call back for any change of heart or worsening of his condition, and that we'd be happy to see him again. IV was removed, etc. But this was a certainly well-written, solid narrative here that would be incredibly protective if we got called back 2 hours later to find the patient dead. So thank you, everybody. I hope that you all found this useful. It's been great joining the team here. I've enjoyed getting to meet and work with many of you. And here's my cell and my email. We're definitely happy to help you, and we're here to make you the best provider that you can and make this the best system possible. So feel free to reach out anytime, call or text anytime, day or night. Happy to help you all in any way. So thank you so much, everybody, and take care.